Hey everyone, it's Dan and Don from theclinicaltrialsguru.com. We are interviewing Dr. Jenny Yip. She's a psychologist in the Los Angeles area. We could have actually done this interview in person. We're out here in Anaheim, Dr. Yip.
Okay.
And Dr. Yip, and Dr. Yip is from the Renewed Freedom Center. They focus on anxiety and OCD studies, which are obsessive-compulsive disorder studies in the Los Angeles area. She has a lot of experience in clinical trials, both for adults and pediatrics. We're going to get into a lot of that. But first, we want to just get a little bit about yourself, Dr. Yip. Tell us a little bit about your background and then your organization that you work with.
Okay, well, good afternoon, you guys.
Good afternoon.
I am a licensed psychologist as well as the executive director of the Renewed Freedom Center. We specialize in the treatment of severe obsessive-compulsive disorder as well as related anxiety disorders within the pediatric setting. So we work a lot with children as young as 3 years old. And we incorporate family work into that because it doesn't make sense to work with kids without involving family members. So that's what we do here. And as far as my background, I've worked with this population for over a decade. I myself was an OCD sufferer, ever since I was a child. So I'm very familiar with obsessive-compulsive disorder.
Yeah, I think that's important. I know in our field, in the psychiatric industry, I often hear that the best doctors, the best psychiatrists or psychologists often have like a personal connection with some type of psychiatric condition, whether it's a family member or themselves or a close friend. So it's very important, and thank you for sharing that about yourself.
You said something interesting that really caught my attention up on the intro is that you've worked with children as young as 3 years old with anxiety and obsessive-compulsive disorder.
Yes. Traditionally, or a lot of the evidence-based, a lot of the literature indicates that OCD, the onset of OCD is, anywhere between 8 and 15 years old, tends to occur in both males and females, boys and girls, and tends to occur earlier with females. However, from what we've been seeing through our institutes, we're getting a lot of kids who are a lot younger. And I think the reason why we're seeing them a lot younger isn't necessarily because it's actually occurring. The onset isn't just occurring younger, it's just that there's more information out there, and therefore parents are a lot more savvy in being able to recognize their child's symptoms, and therefore they get into treatment earlier. And from our research, a lot of the adult population, more than 50%, indicate that they've had these symptoms before their adult period, that they've had it ever since they were kids. I certainly was one of those who had it ever since I was a kid, and there wasn't any information out there regarding children with OCD. So a lot of kids go unrecognized and go undiagnosed, and then they're put on various medications that may be unnecessary.
Are you finding that these young children, is it being created, the symptoms being created as an environment, or is it something that's genetic, or both?
Well, from our research studies, we know that there's definitely a genetic component to obsessive-compulsive disorder. So if you think about it, the way that I explain it to parents and family members is that OCD is kind of just like any other genetic disease, whether it's diabetes, cancer, heart disease. You're genetically predisposed with it. However, there's also an environmental stressor that triggers the genes, that triggers the onset of the disease. So you can have the genetic loadings for the disease and not have it be triggered throughout your entire lifetime. I think as our environmental stressors continue to build, we're just seeing a lot more of it.
Now, Dr. Yip, tell us a little bit about the type of clinical trials that you do over there at the Renewed Freedom Center.
Well, the clinical trials that we do are really about pediatrics with obsessive-compulsive disorder and looking at how the family component has an influence in the severity of the disease.
Okay, so they're more like survey studies, like a historical context. They're taking the data of the participants' story.
Well, we have some questionnaires that we give to family members that measures their accommodation style to the child. Oftentimes, obsessive-compulsive disorders will involve other family members because, for example, we have children who will not touch dirty clothes, and therefore their parents end up touching and doing their dirty laundry for them. Or, we have a lot of parents who will continually reassure their child. And when that happens, it allows the child to continue avoiding. So I guess before I get into all that, let me just explain what OCD really is.
Yeah, please.
The obsessive-compulsive cycle is basically you experience a intrusive thought, an image, it can even be a sensation that causes a lot of anxiety. So the way that so it causes a lot of anxiety, and then none of us like to experience anxiety, and because we experience anxiety, we engage in a behavior that gives us relief from the anxiety. And when we experience the relief, that actually reinforces the whole cycle for the next time around when the intrusive thoughts come up. So, the example that I usually give parents is imagine if you have a child missing for 6 hours. Your anxiety is going to be pretty heightened, right? And you're going to have intrusive thoughts about what's happened to my child. Is my child alive? Has someone kidnapped my child? Is my child just being truant? And then what are you going to do? You're not just going to sit there, right? You're going to do something to relieve your discomfort. So parents will call their neighbors, call the child's friends and family members, perhaps even call schools, call other family members, and then eventually perhaps calling police, if it really gets to that point. And let's say that at each time you pick up the phone, you call, that's your compulsive behavior. And it gives you a little bit of relief because you're trying to find an answer. And let's say every time you hang up, well, the thought comes back because you didn't get full relief. You got temporary relief. You hang up, you didn't get any answer, and what happens? The thoughts come back. Where is my child? Is my child safe? Has something bad happened to my child? And then you get the intrusive thoughts, and then you feel the anxiety rise again, and then you do the next compulsive behavior. Maybe now you're going to go out of the house. Now you're going to check the park, check the convenience stores, whatever, check the schools. And that cycle repeats itself continuously because you're not getting full relief.
Right.
The problem with OCD is that you never really get full relief because we cannot control the type of thoughts we have. We can control how we respond to our thoughts. However, we cannot control our thoughts. And therefore, we all have, catastrophic thoughts. We all have thoughts of, oh, do I have this disease? Or, oh, is my significant other okay? Are my parents okay? However, for the majority of us, we don't take it to the extreme where it causes significant, excessive distress, anxiety, discomfort. For the person suffering from obsessive-compulsive disorder, the anxiety is so high that they need something to give them relief. And so they engage in a compulsive behavior. Another example that I give that many people will probably relate to is if you have a headache. If you have a headache, it's going to feel uncomfortable. I'm sure we've all had a headache, right? And what is the first thing that we do when we have a headache? Well, we reach for the Tylenol bottle. And let's say you take the Tylenol, that's the compulsive behavior, and let's say that you gain relief. You're feeling, I'm feeling better now, right? Does that mean the headache is gone forever and ever? No, headaches are always going to come back. Next time when a headache comes back, are you more likely to go for the Tylenol bottle? Yes, because it brought you relief the very first time. However, let's say you run out of Tylenol this time and you have your bottle of Advil. I'm not promoting any of these drugs, by the way.
Right.
However, let's say you have a bottle of Advil and this time you take the Advil and it doesn't work. So next time when you have your headache, are you going to go for the Advil or are you going to go for the Tylenol? You're going to go for the Tylenol because that is what gave you relief and that is what worked. And that is how compulsive behaviors are reinforced. If it gives you relief, even temporarily, it's going to be reinforced. And then the next time around when you experience an intrusive thought, you will be more likely to engage in a compulsive behavior that gave you some relief. The problem with this cycle is that it's almost like an addiction, that the compulsions don't give you the same relief each time. It's almost like you build a tolerance for it. So even, let's say it gave you a 80% relief a week ago. Well, this week it might just be a 70% relief. And because it's not giving you the same amount of relief, you're going to need to modify your compulsive behavior so that it gives you a much more stronger relief. And that's how we usually see the behaviors change over time, is because you're not getting the same level of relief. You're changing your compulsive behaviors to adapt to the anxiety.
Just like a drug addict.
Very similar,
Yeah,
yes.
very much. Person going down that line of getting addicted, it's less and less effective each time they use it.
Yes.
How would, just give us a short example. I know I don't want you to give away any trade secrets, but how would you treat this? Because one of the statements you made is that obviously these thoughts come to our minds, and obviously we can't control the thoughts.
Right.
So with that in mind, how would you treat someone dealing with this, or at least get them going in the right direction where they can function without having to deal with all this?
Absolutely. Well, the evidence-based treatment is cognitive behavior therapy. And what does cognitive behavior therapy means? Well, cognitive means your thoughts. And so we train our patients, we educate our patients on how to identify those negative, overvalued thinking patterns that tend to trigger the anxiety, and teach them how to reframe that negative thinking pattern, that catastrophic thinking pattern, so that it actually reflects reality more accurately. So we all have negative thinking patterns or distorted thinking patterns. The person with obsessive-compulsive disorder tend to catastrophize everything, tend to magnify everything, and therefore that is the cognitive portion. And then the behavioral portion is pretty much we teach patients how to engage in behaviors that do not reinforce that cycle. So for example, I gave you the example of taking the Advil, right, versus taking the Tylenol. Well, if you engage in a behavior that does not reinforce that relief, then that cycle actually breaks, and our goal is to break that cycle. So within cognitive behavior therapy, there is an approach called prolonged exposure and response prevention. And what that means is that we are going to purposely expose our patients to their fears and insist that they do not engage in the compulsive behavior. That is the response prevention part. So, for example, we're going to purposely give you a headache. We're going to do something to give you a headache, right? And we're going to say you're not going to take medicine for it. And we know that over time, your body naturally habituates to the discomfort. There's no way that your body can stay at a heightened level of anxiety for a prolonged period of time. Your body just doesn't work that way. So whenever you have the intrusive thought of some catastrophic event that you fear will occur, we will tell you to keep thinking about that, keep thinking about that. And we want to generate that fight-flight response. We want to generate that discomfort. And purposely generating that discomfort at a heightened level without engaging in the compulsive behavior through time, you're learning that I don't have to take that Advil. I don't have to take any medication. I don't have to engage in the compulsive behavior, and I still get relief. And we've also done a lot of brain imaging studies that show by actually doing exposure and response prevention, we are retraining the neurochemistry of your brain, thereby which we would usually depend on medications for.
On these treatment procedures that you're discussing, there's currently clinical trials being done to prove these methods?
Absolutely. Research OCD and cognitive behavior therapy.
So it's very interesting for our audience members to understand that there are clinical trials that are done every day, as you can see here, without necessarily testing a medication or a medical device. Oftentimes, treatment methods are being tested. And in this case, these studies are done on both adults and pediatric populations. So, very interesting.
Now, has there been any analysis done to determine in the general population how many people suffer from anxieties and OCD?
Well, I mean, I can definitely tell you that in OCD, the latest research that I've read indicates that as many as 1 in 100 children can suffer from obsessive-compulsive disorder. This is twice the amount that we had previously thought. And within the adult population, it can be as many as 7 million adults in the U.S. alone. So this is in terms of with kids, this is more than the amount of children who suffer from diabetes. So it's a lot of kids. If you think about your average high school, 1 in 100, you're going to have a lot of kids in your average high school who's suffering from OCD. I think the bigger problem is that it usually the people who usually first recognize it is the schools, and unfortunately, OCD can manifest as other disorders. It can manifest as attention deficit disorders. It can manifest as conduct disorders. In fact, we have so many kids who come through our doors who are referred because teachers or parents know that there's a anxiety component. However, they were initially diagnosed with ADHD or as conduct disorder, and they were put on medications that actually exacerbated the anxiety because the medications, the stimulants for ADHD, which is the class of medications for ADHD, actually increases anxiety rather than decreases.
I'm glad
so
you brought
that
that
is
up.
the problem.
Yeah, I'm definitely glad you brought up the topic of medications because, well, obviously, this is a clinical trial show, and most of the clinical trials are about medications, but as we've heard from you, they're also oftentimes done to test out new procedures and new treatment methods that don't require medication. But I wanted to get your opinion as a clinician. What are your thoughts on psychiatric medication?
Well, we really come from a perspective where if we have brain studies, brain scans, MRI scans, PET scans that are showing that through cognitive behavioral therapy, we're changing the neurochemistry of the brain, where patients with medications would be depending on what is the purpose of the medication. I think there is a purpose for those patients who are so severe that it's difficult for them to even engage in therapy. I think that is, that is one purpose. However, the majority of the patients that walk through our door who are already on medications, we usually titrate them off of the medications toward the middle of the treatment program. And for those patients who walk through the door and they're not on medication already, well, the fact that you're able to walk through the door and you're not on medication signify that you're at some functioning level, and therefore, there really isn't a point in putting you on medication unless the person is very resistant to exposure therapy. And if you think about it, exposure therapy does have a very high resistance rate because we are requiring you to expose yourself to all of your fears, those fears that you've been avoiding all of these years. So, of course, patients will be resistant. However, how we tackle that here is by psychoeducating the patient. Psychoeducation is so important within the mental health field because if a patient understands why they're experiencing the symptoms they're experiencing, the mechanism of the fight-flight response, your negative thought patterns, how your behaviors reinforce the OCD cycle, then they learn what they need not to do or what they need to do in order to improve their symptoms or even just to engage in the exposure therapy process.
Now, do you think, going back to the pediatric population and clinical trials, there's a lot of critics out there that say, children and adolescents should not participate in trials. What are your thoughts on that? And then how do you deal with your patients when it comes to clinical trials?
Sure. Well, I think if your child doesn't suffer from a disease, then yes, why put your child in a clinical trial, right? However, a lot of the patients that do participate in our clinical trials are doing so because they either their child is suffering from the disease and they cannot afford the treatment. Cognitive behavior therapy is quite expensive, and therefore we're pretty much offering free treatment in exchange to use your data in our research that will either give more evidence to the effectiveness of the treatment or give evidence to new treatment that aren't previously existing. However, most of the patients who are in our clinical trials are in so because, again, they cannot afford cognitive behavior therapy. So it's kind of a great trade-off, if you can't afford thousands of dollars of therapy, then you're getting free therapy. And CBT, the risk benefit ratio is very, very different. The benefit is extensive, whereas the risk is very, very minimal.
Very minimal.
Just very minimal, which is very different compared to, for example, drug trials.
Drug trials, and I imagine most of your studies are cognitive behavioral therapy studies, but do you guys do any drug trials?
No, we do not do any drug trials. Again, we have done drug trials with adults where we compare the two subject groups, one taking the medications, one going through cognitive behavior therapy, and these are all MRI studies, so they're brain imaging studies. And again, our research has shown time and time again that by going through cognitive behavior therapy, were gaining very similar, if not better, results than those in the drug group.
Now let me, and I know we talked about this earlier, so you guys aren't just doing research, but you also do private practice at this location as well, am I correct?
Yes.
Okay.
We don't just do research, we are also a private practice. So we have an intensive outpatient program where we do have kids coming from all over the country where treatment isn't available in their hometown. I think that's also an important point, is that OCD is still a relatively new disease that we are doing a lot of research on, especially a lot of the genetic studies on. And if you're not in one of the major cities that have experts in obsessive compulsive disorder, a lot of kids are going misdiagnosed. They're being put on medications that are unnecessary. It's unfortunate, however, even clinicians, psychologists and psychiatrists, they are quite uninformed in terms of the how OCD actually manifests. And again, many times they're being misdiagnosed.
Now, who sponsor these trials?
We actually sponsor the trials.
Okay.
We provide a free treatment in order for the data.
Okay.
Because this is not a pharmaceutical trial, so we don't have the money from the pharmaceutical industry.
Yeah, I was just going to ask that question.
An endless amount of money they have.
Yes.
Yeah, and I'm sure they would have no interest in this type of stuff anyways.
Well, they probably don't, because we're probably taking patients away from them.
Yeah, I mean, from what I hear, if CBT, cognitive behavioral therapy, is just as good as medication, if not better, plus no side effects. I mean, who would not choose CBT? Now,
there are people who won't choose CBT because CBT requires work.
Yeah.
And whereas medication, you just pop a pill to feel better. I think a lot of patients who are newly diagnosed and who are considering therapy, they want that quick relief, and they want just a pill to fix them. And I think a lot of them are uninformed in terms of the side effects that come with a lot of the SSRIs that are given, including weight gain, sleep difficulties, loss in sexual drive. All of those factors are important considerations. And if you want that fix, that quick fix, again, you can take that Advil or that Tylenol all you want. It's not going to solve the problem. The headache will definitely come back. Yeah. Whereas CBT, yes, you're going to have to put in that work. It's like exercising your brain, right? If you don't go to the gym, well, then your body's going to look like you haven't gone to the gym. Your brain is pretty much the same thing. You have to exercise the muscles in your brain, and that's basically what CBT is. You have to put in the effort, and it is a lot of effort with exposure therapy.
Excellent point.
As we wrap up, Dr. Yip, because we know you got to go, is there any evidence that CBT works for something like schizophrenia, bipolar, or severe depression?
CBT definitely has a lot of evidence with depression and, mood disorders. So mood disorders including bipolar. Schizophrenia, I can't speak on because I am not familiar with schizophrenia. However, people diagnosed with schizophrenia, I would assume that they would need both the medication as well as the behavior therapy.
Okay. Well, if someone wanted to reach you or your organization, can you tell our audience how they would do that?
Yes, they can definitely reach us on our website, which is www.renewedfreedomcenter.com. And they can definitely find us on Facebook, which I believe the link is facebook.com/renewedfreedom. We're also on Twitter, so twitter.com/renewedfreedom. And we're actually going to be putting on a few PSA, really lighthearted PSAs on YouTube relatively soon, because our passion really is to disseminate knowledge and educate the public and also destigmatize the disease. So we'll be doing that quite soon. And guess what our YouTube link is? It's youtube.com/renewedfreedom.
Okay.
Very good. And we'll have links to all of this on our blog as well. And Dr. Yip, we thank you again for your time today.
Thank you very much. It's very interesting.
Thank you. Have a great afternoon.
You
do
too.
the
Take
same.
care.
This is Dan and Don signing off from theclinicaltrialsguru.com.